I request Dr. Naresh Kumar Yadav to speak on the next topic. Dr. Naresh Yadav is a very well-known vitreoretinal surgeon. He's head of the vitreoretinal department at Narayan Nethralaya, Bengaluru. And he has done his fellowship from Shankar Nethralaya, Chennai, and he has numerous publications to his credit and presentations to his credit, and a very familiar figure in the vitreoretinal circles. So thank you, Naresh. Over to you for the next lecture.
A very good evening to one and all. At the outset, I would like to thank Dr. Muralidhar for letting me be a part of this IC. I will be speaking on how to decide between gas and oil in vitrectomy for RRD. So basically, there are various ways of tackling a detachment, like pneumatic retinopexy, scleral buckle, PPV. I still do pneumatic retinopexy. I will be showing a few examples. And as Dr. Muralidhar also said, that buckle is losing its popularity because the indications for PPV are much. Every one of us is more familiar with PPV, but scleral buckle is an elegant surgery, and I think everybody should be comfortable in doing scleral buckling also. The other thing is that, see, this is a case of pneumatic retinopexy. So you can see on the left side, there is a detachment, partial detachment. There's a single HST, and I did pneumatic retinopexy, and the patient did well. Similarly, there's a buccal case, traumatic dialysis, so buccal has to be done. So basically, you need to treat the detachment, what the detachment wants, not what you want to do. So that way, you will do justice to the patient. And the other thing is, you can always do a chandelier-assisted scleral buckle. So the advantage is that you don't have to repeatedly get up, put the indirect, and most of us are comfortable doing vitrectomy. So you can use a chandelier to assist your localization and cryo also, and it's a good teaching tool also. So basically, indications for pars plana vitrectomy is extensive PVR more than grade C, GRT, posterior breaks which are not buckleable, or multiple breaks. So if they're involving 2-3 quadrants, then putting a buckle is going to be very morbid. So most of us prefer to doing pars plana vitrectomy in such cases. This is not a complete list. This is just an overview. So why is silicone oil overused as a tamponade? I know a few surgeons who just use silicone oil in all cases. Any case of detachment, they'll put oil. So, and then some people think that if you're not able to do a good laser, you put oil, you can add laser later on. There's a faster visual rehabilitation, and there's a lesser incidence of PVR in oil-filled eyes. And if the patient is not able to maintain prone position, choice of tamponade in a one-eyed patient, and patients who want to travel by air. And the other could be because of the availability of optos, fundus photo. Everybody wants to feel nice on the first post-op day. If you fill oil, you can tell the patient, see, this was the detachment, now the retina is attached. So these also make, I think, most of us to overuse silicone oil. So the misconceptions are that inferior breaks, gas won't work, multiple breaks, gas won't work, total RD, gas won't work. And some people think that if you are not able to do a good base excision, put oil, that will take care. It's not like that. If you leave a lot of vitreous behind, whatever tamponade you put, there's a high risk of PVR. So a good vitrectomy, thorough vitrectomy is a must. And the retina is stiff, and you have not done a good membrane peeling, you put oil, it will settle on the table, but it's likely to again lift up. So this is, oil is not a shortcut for a sort of shoddy work. You have to do a good work, and then you have to use the adequate or the right tamponade. So basically, many of us find reasons to inject oil. So the reasons could be, I'll just discuss more on that. So this is one inferior break. You can see there are one inferior break. So ideally, buccal also could have been done, but there was a PC rent. There was some vitreous in AC. So I thought of doing vitrectomy, clear the AC from the anterior chamber, and then I have done vitrectomy with gas fill. Most of the times, if there is an inferior break, I still like to support it with a buccal. So here, buccal also was done, belt buccal. This is another case. Multiple breaks are there. So such cases also, they can do very well with gas tamponade. It's not mandatory that you put oil in such cases. So this is another case. There were multiple inferior breaks. So that also I supported with a 240 band, and then vitrectomy was done with good results. And these are all relative indications for oil. Sometimes if there's a large PC rent, the lens starts fogging when you do FAE. So many of surgeons think that, okay, they're not able to do a good vitrectomy, good laser, they put oil. So this is a very nice solution. You can put visco there, or you can go with a silicon tip flute and clear this, be persistent, do a good laser, and you can put gas. The other could be multifocal IOLs. So because of the various diffraction, so many people find it difficult, and then they take the help of oil. Similarly, SFIL also. In SFIL, once you do FAE, the air comes into the AC. Then all procedures become difficult. So one way could be to use PFCL to flatten the retina, do the laser, and then you can do PFCL, air exchange, and then you can use the right tamponade. But in this case, the patient was one-eyed SFIL, and I have used silicone oil. So indications for silicone oil could be one-eyed patient, not able to maintain position, wants to travel by air, and the RD post-pars-plana vitrectomy. Most of such RDs, it's very severe PVR, it progresses very rapidly, and most of these need silicone oil support, and similarly, GRT also. This is one case of GRT. So there was a vitreous hemorrhage also. So good vitrectomy is a must. And in this case, the GRT edge was extending posteriorly, and it had caused avulsion of a major vessel. And that was the reason for the bleeding. And once you do a good vitrectomy, then I'm using PFCL to flatten the GRT, and then laser is done. The risk of PVR is more in GRT cases, so you should not really do unnecessary cryo, and you should not treat the bare RP by doing cryo. But with a wide angle, most of us now really don't use cryo, so good laser is a must, and then you can do either PFCL air exchange or PFCL oil exchange. This is another study. It's not mandatory that all GIT cases have to be you have to put oil. There was a study where they did 48 eyes had C3F8 gas and 40 eyes had silicone oil. And all had 23 gauge PPV with no buckle, and the final attachment rate was equal in both the eyes. So if the GRT is superior, definitely gas is an option. This is another case of myopic macular hole with detachment. So in such cases, most of us want to use silicone oil because getting a laser burn also is difficult because of the chorioretinal atrophy. So sometimes gas may not be sufficient. And the other issue is that if you put brilliant blue, it can go into the subretinal space. So you can use a little PFCL and then put brilliant blue, and then gradually you can aspirate the PFCL so that it stays for a couple of minutes in the eye, and that way it stains. So the risk of subretinal migration could be less. But studies have shown that it really does not make much of a difference if some amount of subretinal dye is seen. It's not really much harmful. And ILM peeling is preferable in all myopic patients if it's a myopic foveosis or myopic hole with retinal detachment. So you can either drain from the hole or you can create a new break and new drainage retinotomy. So here I'm using PFCL, and ILM peeling is being performed. One issue is that the axial length is long in these eyes, so reaching is sometimes an issue. So you can use 23 gauge instruments are longer, or you can have specially made instrumentations like flute needle. You can use a finesse loop that will give you a little more space, and the sclerotomies also can be a little posterior, and they can be angled appropriately so that you traverse the short distance towards the posterior pole. So this patient, then oil was put, And such cases definitely oil is required. And PVR is very common, almost, that's the most common cause for recurrent RD. And pre-op PVR, if it is present, that is a risk factor. And you should not forget that past planar vitrectomy itself is a risk factor for post-op PVR. So wherever indicated, try to do buccal, because post-buccal, the risk of the rate of PVR is very less. If there's an infective closure of breaks, large breaks, formation of new breaks, incomplete removal of vitreous base and shaving, intraoperative bleeding, post-op inflammation, inadequate tamponade, not maintaining position, and perisilicone oil proliferation. So these all can cause PVR. So this is another case developed PVR after silicone oil injection. So under oil, I am peeling the membranes. So try to peel the membrane from the disc to the periphery. So the posterior retina is a little stiff. You are going to get a better counter traction. And if there are limited membranes, under oil is good enough. You don't have to really remove the oil. So here it was done under oil. And then just go to the next one, sorry. This is another case of recurrent detachment. So here also the membrane is being peeled. I'll just try to go fast. This is the, so membranes will peel from the edges, cautery was done. I think this, I'll just skip it. So basically oil has its own complications. You can get BSK, corneal thinning, there's a corneal endothelial loss. And glaucoma also is a major factor. It could be mechanical obstruction, pupillary block, emulsified oil going into trabecular meshwork, cataract. And there's another this thing that sometimes there could be unexplained visual loss after silicone oil injection or after oil removal. So that is blamed on the potassium theory, sink theory. The vitreous acts as a sink for the potassium that is released from the Muller cells. So when the fluid is less, so that sink does not work, and the intracellular potassium increases, and it can cause apoptosis and cell loss. So gas also has complications. It can migrate into the AC, raised IOP, and poor vision with gas in vitreous cavity, and PVR progresses rapidly. So to conclude, both gas and oil are good tamponading agents. In patients with RD and PVR, either oil or gas appear comparable. Overuse of oil is common. Many cases can be managed by gas tamponade. And I will reiterate again, do the surgery the RRD needs, not the surgery you want to do. Thanks for a patient hearing.
Thank you, Naresh, for elegantly, taking us through this confusing, this one of gas versus oil and when to use oil.